Good morning, everyone. Welcome to the Institute of Medicine of Chicago. Our webinar today is the role of non-governmental organizations in public health and the status of public health funding and infrastructure in 2024. So my name is Deborah Hodges. I'm the Association and Program Manager with IOMC, and I've been with the organization since 2020. So I just want to brief you for a few minutes here on a couple of activities in today's agenda, and then I will turn it over to our esteemed speakers. So we're going to just give you a little recap here of a couple programs that are coming up in the month of December. Then we'll have the full presentation with Dr. Pence and Dr. Benjamin. We'll also have a question and answer session, so you'll be able to submit your questions and for about a full 15 minutes or more. And then we'll do a closing. So if you're with us for the very first time, welcome. Let us tell you a little bit about the Institute of Medicine of Chicago. It's an independent nonprofit organization of distinguished leaders in the health field who collaborate to improve the health of the public. Drawing upon our expertise of our diverse membership and regional leaders, IOMC addresses critical health issues through a variety of approaches, including education, research, communication of trusted information, community engagement, and most of our activities involve work groups on specific areas of programmatic interest. We are a 501c nonprofit organization. Our upcoming event is going to be after this webinar, is going to be on December 14th. That will be the 9th State of Health of Chicago. This is a biannual event that takes place. It acts as a convening and report card for what is taking place in healthcare and public health, and it identifies critical health issues that we hope to address for the next 2 years with IOMC and our strategic partners. We are very proud to say that Dr. Shikar from Kaiser Permanente, the Kaiser Foundation, Health Plan and Hospitals, is our keynote speaker. We will also be giving honors to Dr. Allison Arwadi, who is the immediate past commissioner of the Chicago Department of Public Health. She is on her way to join the CDC in January. So we are awarding her the 2023 Outstanding Leadership Award. We also have a panel forum of 9 senior executive leaders and speakers that will be part of the State of Health of Chicago. So there'll be a dynamic discussion that'll be moderated by Health News Illinois in regards to various areas of public health and healthcare itself. The event is from 4 o'clock in the afternoon to 8 o'clock in the evening. The first 2 hours are the educational convening, and the second 2 hours are networking. So we hope that you'll have an opportunity to join us. We want to thank our sponsors who support IOMC and also specifically the State of Health of Chicago, Midwest Business Group on Health, Golden Square, Johnson & Johnson, Health News Illinois, and also the Portis Foundation. Thank you again for your support. Today's speakers, as I mentioned, are Dr. Pence, who is the president of the Institute of Chicago. He's also the Senior VP of the Osteopathic Accreditation at ACGME. And we're very proud to have Dr. Georges Benjamin, who is the Executive Director of the American Public Health Association. I also want to give credit to Dr. Peter Orris, who helped arrange Dr. Benjamin to be with us today. Dr. Peter Orris is on the Board of Governors for IOMC and also the Program Committee for their input in what's taking place. So Dr. Pence, at this time, I'm going to turn the presentation over to you and to Dr. Benjamin. And once again, welcome everyone to today's webinar.
Thank you very much, Deborah. And again, I want to welcome everyone to the webinar today. I want to thank Dr. Benjamin for being with us today. And we look forward to his presentation. I would like to give you just a little overview on Dr. Benjamin. He is known as one of the nation's most influential physician leaders because he speaks passionately and eloquently about the health issues having the most impact on our nation today. From his firsthand experience as a physician, he knows what happens when preventive care is not available and when the healthy choice is not the easy choice. And as executive director of APHA since 2002, he has led the association's push to make America the healthiest nation. He came to APHA from his position as secretary of the Maryland Department of Health and Mental Hygiene. Dr. Benjamin became Secretary of Health in Maryland in April of 1999, following 4 years as Deputy Secretary for the Public Health Services. As Secretary, Dr. Benjamin oversaw expanding and improving the state's Medicaid program. Dr. Benjamin of Gaithersburg, Maryland, is a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He's board certified in internal medicine and a master of the American College of Physicians, a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, an honorary fellow of the Faculty of Public Health, and an honorary fellow of the Royal Society of Public Health. In 2008, 2014, and 2016, he was named one of the top 25 minority executives in healthcare by the Modern Healthcare magazine. In addition to being voted among the 100 most influential people in healthcare from 2007 to 2018, and in 2021 through 22. In 2023, Washington Magazine voted Dr. Benjamin one of the 500 most influential people shaping health policy. Dr. Benjamin, I'm going to turn the podium over to you, and again, welcome and thank you today.
Hi, Deborah. Thank you very much. And Dr. Pence, I really appreciate you allowing me to spend some time with you this morning. Why don't we just go to my next slide? I just wanted at this point, I don't have any financial conflicts of interest with today's presentation on the financial side. Next slide. And I want to just run through this, really three things. I'm going to talk a little bit about the operating environment that public health is practicing in today, the role of public health practitioners, as I talk about as the chief health strategist of their communities, and then talk in some detail about what we think is needed to build a modernized public health system. Next slide. So public health is a collaborative practice, and it's the ultimate collaborative practice. We talk about that a lot in medicine, about collaborative practices, but it's clearly a federal, state, local partnership on the governmental side, but it has a slew of non-governmental partners that participate in the actual delivery of services, the policy development that goes along with it, and actually efforts to improve the public's health. Next slide. And I like to say that this was someone where it was a very thoughtful system, where someone sat in the room and said, this is what we have to do, this is what we should do, this is the pieces that we need to have. But it's really developed over time. It really wasn't designed or resourced to meet the strategic national needs. And if you can think about it, the national needs of any nation changes over time. And the system that we have is not one that was designed or resourced to meet those strategic needs. It's really a patchwork of programs, funding streams based on someone's area of interest at the time, often important areas of interest, but it's really a patchwork. And in many cases, those programs are incomplete or inadequately funded, or over time, the needs of the nation have changed and are different than the way the funding or the programs were originally designed. And then when you add on top of that emergency preparedness, these also developed over time through a series of episodic funding streams and programs, which also have not been sustained. Now, you might argue that this pattern is also true in many ways of our healthcare delivery system, but I would argue that the healthcare delivery system has more resources and has the capacity to evolve a lot quicker than the public health system for a variety of reasons we can talk about. Next slide. It's governed and in an interesting way. Just remind folks that while there are a lot of people interested in public health, The governmental public health entity is the only entity that by law has a legal responsibility for the health of the community. There are many of us who care about the health of the community, but the governmental public health institutions are the only ones that actually have that responsibility by law. We talked about it being managed in many ways as a partnership. So often, sometimes governmental public health is on both sides of the interaction. Sometimes they're both the deliverer of services and the regulator of services, sometimes for the same services in which they deliver. But they do often, as I mentioned earlier, rely on lots of nonprofit organizations, both to expand their operational capacity, as well as to serve as an early warning capacity. For example, the Association of Public Health Laboratories, APHL, for all practical purposes, does the bulk of CDC's laboratory work in other nations, particularly under-resourced nations around the world, developing countries. A lot of the work that's done on the laboratory side is done through the Association of Public Health Laboratories. The State Health Officers Association, ASTO, and the Local Health Officers Association, NHO, also do a lot of engagement of their members and serve as a linkage to the federal government when they need to pull together the various governmental entities to respond to a range of threats and health needs in the nation. They're also, if you've seen one health department, you've seen one health department in terms of their size and their complexity and how they're organized, but they're really four basic at the state level models. One where they're centralized, where everything's under the state health department. There are shared governance where the governance between the state and locals are truly shared. There are mixed models where there's a combination of both the centralized and shared model. And there's a totally decentralized model where while there is a very weak state entity, most of the power is in the locals on a day-to-day basis. Next slide. And of course, the civil society organizations, this happens to be the strategic plan for APHA to give you a sense of what we do. But the civil society organizations, the nonprofits that support the health of the nation, American Public Health Association, the Heart Association, the Lung Association, other professional societies like the AMA, the American Osteopathic Association, et cetera, we all work with various components of our partners, depending on where we are. We do a lot of education and advocacy. We do policy development. We do a lot of workforce and skills development. There was a time when the American Public Health Association was actually the entity that accredited all the schools and programs of public health in the country. That now gets done through an organization that we spun off called CEF, which is the Council on Education and Public Health, and we basically serve as the kind of the holding company for CEF. But CEF is an independent entity that accredits all these programs. But what we do is we try to do enhanced skills development. So like most associations, we have annual meetings, we have webinars, we have things to try to help develop the skill set of those people already in the field. And people that are going through school to the extent we're doing things that they're not getting in their classes. We're all involved in research at a variety of levels, from practice research to bench research. We provide a lot of networking, and we do accountability. There are civil society organizations like the Joint Commission, which provide oversight and accountability. We have two, the National Board of Public Health Examiners, which accredits people who have training in public health, and the Public Health Accreditation Board, which actually certifies and accredits governmental public health entities like your state and local health departments. Next slide. I'd like to point out that public health operates in an incongruent environment. So if you could maybe just bring up those three things. Something happens, and then the federal government funds the activity, often too late, and tragically the money often goes away too soon. Then if you click it one more time, you'll see that the performance expectations far exceed both the crisis, the money, and that's one of our challenges, is that the funding kind of comes in boluses. Something bad happens, we throw a lot of money at it, it goes away, and then we begin to withdraw the funding, really sometimes before the event is over. By the way, we're seeing that right now with COVID. As you know, COVID isn't totally gone away by any means, and yet they're now in the process of withdrawing funding, the infrastructure supports for the nation's COVID response. Next slide. I'd also like to point out that the basic work of public health has not really changed. We talk about public health having goals of assessing the community, then doing the policy once we have that assessment, and then doing things to assure that through what we call the 10 essential public health services. And doing that, public health is really a full cycle, full service entity that works to try to ensure equity and health in any particular community. But it hasn't really changed. It hasn't changed for 50, 60 years. The basic work in which we do really hasn't changed. I was reading an article the other day about a rabbit kitten, where a kitten was found to have a rare case of rabies. It was a kitten that had been picked up, had been taken home. A few days later, got ill. They took the kitten to the veterinarian. The kitten died, and then, of course, they did an autopsy, and they discovered the kitten had rabies. And of course, they had to then give rabies injections to all the people the kitten had been associated with that cat. Having said that, the real question was, where did this rare case of rabies come from? Because this strain was unusual for that part of the country. And that epidemiological assessment goes on today. It's silent, it's behind the scenes, nobody knows what's going on, that is happening right now. But at the end of the day, they will hopefully figure out where that cat got infected, and be able to address it from a population health perspective before we have lots of rabies cases and the introduction of a new strain of rabies into a part of the country that had not seen it previously. And that's what public health does. That's the basic work that happens quite frequently behind the scenes. Next slide. But interestingly enough, while the work hasn't changed, the practice environment has dramatically changed. The fact that we're seeing more and more of epidemics, big epidemics at the same time. And right now we still have, while COVID was going on, we still have a monkeypox epidemic, an obesity epidemic, an STD epidemic, epidemic of gun violence. There are still lots of other things that we have to deal with, growing mental health issues in the nation on a population basis that we have to address. What we learned during COVID was the issues around fast science, the fact that we can take science that has been evolving over 20 years, but put it to practical use very quickly. That mRNA vaccine was a result of 20 years of really good, solid, basic science, but the implementation science was very quick. As you know, for the first time, we created a vaccine in really under a year, proved its effectiveness, and deployed it in the arms of Americans. Over 200 million people have been vaccinated, and that's within the United States, and that's a phenomenal accomplishment. And we were able to do this while researching it at the same time. As you know, research has historically been fairly methodical. It's someone gets an idea, they test it, then someone challenges it, it gets tested again. And after about 10, 20 years, we kind of understand what we believe is the preponderance of the evidence, and then we put that out as fact. Well, that's changing. That's now happening over hours, over days, over weeks, where we're doing this fast science, where we're beginning to rapidly put information out into the ecosystem. A lot of it is being debated in the public sphere long before we have the preponderance of evidence that something is working. And again, we saw that a lot with the mRNA vaccines and even some of the antiviral agents, where we were taking things we thought might work off the shelf. And that caused a lot of controversy. The hydroxychloroquine debate. was an excellent example of the idea that someone thought something might work, and then that became lore. And before we could prove that it didn't work, we saw people using it, and we had elected leaders, unfortunately, practicing medicine when they should have not made those public pronouncements the way they did. Next slide. And we know that our population is changing. We're a very different population today than when I went to medical school. We have many more people with immune dysfunction. We have many more people who we have purposely undermined their immune systems with high-dose steroids, with cancer chemotherapy, with diseases like HIV/AIDS, with newly discovered autoimmune diseases that we're now understanding the pathophysiology of. We have a much higher at-risk population today than we did, when I first went to medical school many years ago. The communications environment that we're in, of course, with social media and the internet, the misinformation and disinformation we're seeing, which now drive health behavior in ways we've never seen before, which now we in the health community have to address, and a range of disruptive technologies. We thought we had our hands around tobacco, and then we got vaping. And now many of the things we were doing with vaping bring back the same debate we had with combustible tobacco. The use of flavors, the role of nicotine as an addictive substance, a whole range of behavioral things that we thought we had gotten our hands around, but now disruptive technology comes around. And interestingly enough, the question about, does the FDA really have the authority to regulate that effectively? Even though for the first time we got FDA the authority to regulate tobacco and its products, this is still being litigated in the court. Public health used to argue that we do our best work, nothing happened. We were very invisible. We were happy with being invisible. Now we're in the fishbowl. We're very much visible now. And to that end, we're doing that in an environment where there's a growing distrust of, in essence, expert advice in science. Public health is only one of the people that people are questioning, but police have been questioned, teachers have been questioned, authority has been questioned. And at the end of the day, a lot of this has resulted in health policy now being overtly very political. Something that was never political in the past has now become extremely political, even when articulated by trusted messengers. Next slide. So I would argue one of the central challenges for the nation now is, how do we build this next generation public health system, understanding the work hasn't changed, but the practice environment has, and how do we structure and resource the nation's public health system to meet the strategic needs of the nation, to go from that patchwork system that we had to a system which is designed to give us what we need in terms of improving the health of our nation, recognizing that as a nation, we spend over $4 trillion on health and healthcare. And yet we're at the bottom of the industrialized nations in terms of our health outcomes. Not taking things away from the miracles and the amazing things we do as a nation, providing health and well-being of our nation. Next slide. So many folks have looked at this idea what the next generation public health system ought to be. First of all, we ought to fully integrate these two systems. We're the only nation in the world that has a separate public health system and a healthcare system. And so we need to pull these together to address the data infrastructures. The ability for us to talk and share data, the way Uber and Amazon pick a food delivery service can do. We ought to be able to have this technology is there. We just don't do it. We need to fully integrate our systems. We need to have the comprehensive capacity to track and evaluate pathogenic organisms all around the world. We've got the genetic tools to do it. We just haven't linked these tools together, and there's an effort to do so. We do have a robust system to forecast disease as a tool. The federal government now has a disease forecasting system at CDC, and we need to enhance it and make sure we can use it for prevention and early intervention. We do need to have a workforce with an enhanced skill set. I'll come back to that in a moment. We need to rebuild the trust that we have in our system, which in many ways we've lost, and enable that trust so that we can improve public health science literacy throughout our population. We need a much more scientifically literate public, which is armed with the facts. We know that the public is looking for that information, but they're using Dr. Google and often untrusted medical sources to do this. And I often argue that public health, it's okay for public health to be political, but it's not okay for public health to be partisan. And I think that's the difference. Anytime you're doing policy, you're going to have to do that through a political lens. Timing is everything. Understanding political science as a science is important for public health practitioners to do. But what you cannot do is be partisan as part of that process. Next slide. I would argue that to have a system that's robust and sustainable, which would be ideal, the public health leader needs to serve as the chief health strategist. Now, when I was both the health commissioner in Washington, D.C. and the secretary of health for the state of Maryland, I saw myself as the chief health strategist. That did not mean that I ran everything. It means that probably my greatest ability of influence was through persuasion, to convince people to do something that we needed to do, to spend not only my money that I had, the $4 or $5 billion that I had under my control, but to use those dollars to leverage other people's dollars to do the right thing. That agency has to provide all 10 essential services, or make sure that somebody provides those 10 essential services we talked about, that these data systems deliver not only data, but timely data. When I was a health commissioner in Washington, D.C., we were looking at infant mortality. Infant mortality was a very, very important thing. In fact, it may have been the most important program that we had. We were trying to focus on infant mortality, but interestingly enough, we were looking at infant mortality 3 years in the rear. When you didn't have that many babies who died before their first birthday, but it took us that long to get the data, and we needed to have a much more robust system in order to make data-driven decisions early in our process. We also need to harmonize the statutory authorities. I mentioned that public health has the legal authority to do what we do, but we need to have a way to actually harmonize that across our systems. We need sustainable funding that's adequate. We need to do this through partnerships and through accredited systems that are accountable. Next slide. And obviously, it has to be a system that can provide and address any threat that's available. Infectious disease, chronic diseases, climate change and severe weather, product contamination, injury, terrorism, toxic exposure. All these things are on our plate. If it hurts people or kills people, it's ours. And we need to address this. And, you know, this also means we have to do things recognizing upstream the social determinants, including racism and discrimination as a part of that. Next slide. And we talked about skills. There's some skills sets that we have. You know, we used to talk about epidemiology and statistics and mental health and health administration as core competency skills for public health. But we also need to add a whole range of new scientific skills. Genetic science and our understanding has truly evolved, and we need to be able to use that. Leadership skills, I mentioned the politics, but meta leadership, where we're doing not only managing what we know we control, but also managing around us, influence around us is an important skill. Diffusing conflict increasingly is becoming a problem. And when I went from being an emergency doc, the next day I became the public health commissioner. I became a regulator on that Monday morning. On Sunday, I was an ER doc. On Monday, I was a regulator. We need to do a better job of teaching public health people how to be regulators before they're in those jobs. And obviously learning to be strong advocates as we go forward. Next slide. So I'll just give you a system, what I think such a system would look like. So imagine asthma, obviously a common clinical condition. Minorities are disproportionately impacted by this disease. It's a major barrier to kids going to school. We know that the root cause of poor control by clinical and social determinants. There's a range of social determinants that exacerbate asthma, you know, roaches, dust, you know, where you live, the quality of the air conditioning and the air conditioning systems where you school, where you work, or you play, or you live. All those things are important. But if we understand that, we can craft broad solutions that address both of them. So next slide. So remember, we have an outbreak, meaning that on a particular day, in a particular community, at 4 different hospitals in that community, they see cases of asthma. These are severe enough that these kids had to go into the hospital to be cared for. And they're small enough numbers that no system would have picked them up. You know, the hospital, oh, this one only saw 1, this one saw 3. It's not uncommon for them to see 3 kids in the ED on a particular day. They all had different insurers that covered them, or in one case, uninsured. But nobody would have normally picked this up. But let's say we had a system which recognized that we had these kids, and we call this a cluster, just as though these kids all had measles. So imagine we did this for chronic diseases like we do these for infectious diseases of concern. Next slide. So public health, because it's a cluster, gets notified. And they do the classic epidemiological investigation. They understand when they're looking at, oh, interestingly enough, all these kids went to the same school, even though they lived in different parts of the community. And they all ended up getting sick, going to the emergency department in a different place. But the key factor was they all missed school on the same day. Next slide. But what they did discover was all the kids rode on the same bus to school. And so when they looked at that bus, they discovered the bus had a broken tailpipe. Broken tailpipe, toxic fumes, kids absorb those, inhale those on the bus, more asthma attacks, kids go to the hospital emergency department. Next slide. So the hero of the day, of course, I would love to think it's the public health people, we did what we did, but the real hero of the day is a bus mechanic who goes in and inspects the bus, fixes the tailpipe, inspects other buses, because that's their practice when they find out there's a defect, and they fix some other things that need to be fixed on the bus. And you do that if you click that. This involves a multi-sectorial engagement between the school system, the private hospital, the public health department, and transportation. And when you do, if you click it one more time, you'll find that if you actually address this from a social determinants perspective, linking all of these things together, you can reduce emergency department visits, you can save money, you can improve the health. You can also reduce disparities, realizing that the underlying health disparities with asthma is already there. You can reduce school absenteeism, which also, as an independent determinant of health, can be addressed. And of course, the transportation system is much safer because you had a system that both crossed over on health and transportation. Next slide. So I often get asked why invest in public health. And I love this quote because many of you know the Wall Street Journal tends to be very conservative newspaper. This was after COVID, but they pointed out the fact that an infectious disease could crash the economy and that we probably needed to invest in public health. I love this quote because it really, in my mind, lets us know how important public health can be if we really invest in it. And it's just important to do each and every day. Next slide. And then finally, one of the things that we often don't do in public health is we don't tell our own story. We always let others tell that story. And one of the problems with public health is that, again, when our best work is done, nothing happens. And some of you may have seen these signs on construction sites where they say, 0 days, no injuries. We ought to be able to do that in public health. Today, you got up, you got to work, nobody crashed in their automobile because we built safe cars. Nobody got sick from the water because the water was safe to drink. Nobody had asthma attacks today because we addressed the air that was clean. And we need to do a better job of articulating that on an ongoing basis. So with that, let me stop, and I'm happy to take any questions.
Thank you so much, Dr. Benjamin, for a wonderful presentation and certainly giving much insight, not only to the needs, but certainly how your entire department functions. We do have a couple of questions in the looks like in the chat. One of them is, have we measured the level of public trust in the public health system leaders and comprehended it, compared it to its baseline pre-pandemic? Is there a concerted strategic effect to mitigate the lack of trust?
Yeah, there have been numerous studies that have looked at trust in a whole range of health providers, including public health. And there has certainly been an erosion of trust in public health workers in science, et cetera. Interestingly enough, we're still, much more highly ranked than members of Congress, who are quite frankly at the bottom, and of trust in many surveys, and other elected officials. But interestingly enough, like anything else, people like their member of Congress, but they don't like Congress. They like their doctor, but they don't like medicine or the healthcare system. One of the differences has been that many people don't know their health officer. They don't have an intimate relationship with their health officer. And one of the things that happened during COVID was certainly you had these people now telling you had to do all these things that nobody even knew existed. And nobody had any idea that they even had the authority to lock down things, even though we've been closing restaurants and closing pools and closing streams for years, for hundreds of years, in fact. But people just didn't know we were there. And so I do think that we need to do a better job of socializing, engaging the public and talking with them up front. There's an enormous effort to begin rebuilding trust. The best way, trust is easy to lose and hard to gain. So the best thing to do is, of course, get out, engage the public, get them to know you, do what you think is right, but always do what you say you're going to do. And when you make a mistake, own up to it.
Thank you, Dr. Benjamin. Another question and sort of commentary is, can you elaborate on what it means to be a chief health strategist? And of
Sure.
course, healthcare or health department leaders are politically constrained and can't just speak their mind publicly. Maybe they can, to a degree, tell leadership what needs to happen behind closed doors. So I'll start with that part of it. So how?
Yeah. It's a leadership function. It's first of all, first thing you have to do is say that that I'm in charge. It may be metaphorically I'm in charge, but if someone sees a problem, you don't say it's somebody else's problem to fix. If you are the health commissioner or the chief health person in your community, the first thing you ought to do is go pull the statute which empowers you. I can tell you that the statute that empowers the Maryland health officer and the DC health officer, the two jobs in which I know very well, is that basically it's real clear that you're responsible for the health of that community. It's very clear that says right up front, you're responsible for the health of that community. So that doesn't mean that you have to do everything, but it does mean that you have to employ your resources, which may certainly mean just bringing a bunch of people together, say, here's the problem, here's the data, here's a solution, and work with people to solve it. Obviously, you can't do everything. You have to prioritize. And part of being a good politician in these roles is knowing when to act, when not to act, when to have someone else manage the problem. And that requires skills. You've had several health commissioners in Chicago who have been very effective at doing that. And you've had a few that have not over the years. But I do think it's important that you learn those skills. And you're not free to say anything you want to say. But if it ever gets to the point where you don't think you can do your job, then you should probably go find another job to do.
And you sort of answered the rest of this in one sense, but just to comment, does being a chief health strategist mean our public health leaders need to take a greater risk to their jobs to really speak honestly about the public health issues publicly, build trust and strategize? Otherwise, how do we build public trust. You sort of touched on that, but anything else to say?
Sure, I'll tell a story. There was a young man by the name of Seabert Coop. As you know, he was Surgeon General of the United States. Actually, the American Public Health Association, we opposed his appointment as Surgeon General. We were very much concerned with some of his ideological views around reproductive rights. It turns out that it turned out not to be an issue. He followed the science, but he served in an administration where the president wouldn't even talk about HIV/AIDS. That's President Reagan, and Dr. Koop decided to speak his mind, he became the nation's champion around advocating for HIV/AIDS for all populations at a time when all populations were not respected. We're talking particularly our gay and lesbian community. He understood the importance of protecting everyone by speaking out on HIV/AIDS. We've also had people, the CDC Injury Center director, who spoke out on firearms at a time when speaking out on guns was a real problem. In fact, the CDC Injury Center almost got defunded over the work that they did at CDC, speaking truth to power and doing really good research around the risk of guns. So, yeah, there have been many public health people who have done the right thing. The health commissioner in Michigan, the state health officer in Michigan, she was very active during COVID. She even began to get threats. Eventually, she did step down, but again, speaking truth to power, the governor, by the way, did have her back. So she did have a governor that was very supportive of her when she was the health officer.
Thank you for those examples and bringing back thoughts from the past in some sense based upon, I remember some of these commentaries that you were just describing. We need to remember that. Another question is, what is the importance and effectiveness of the APHA Code of Ethics?
Yeah, we've got a code of ethics. That's on our website. So you can go to apha.org, or you can type in APHA Code of Ethics. It should come up. We felt that working with some ethicists and our law and ethics sections, that there needed to be a kind of a code of ethics for the field. So the code of ethics that APHA has crafted does represent what we view as the code of ethics for the field. And it's a way of hopefully principled thinking around problems in the practice. And, other disciplines, the AMA has a code of ethics, and American Osteopathic Association has a code of ethics, and American Nurses Association also have a code of ethics. We felt it was important for public health workers, many of whom, by the way, cross all those disciplines, but to have a separate code of ethics. And by the way, our code of ethics aligns with all the others as well.
Thank you. Just thinking about something I was thinking about, based upon obviously the many successes of the public health as well as the challenges. All of us have things that sometimes sort of keep us up at night thinking about things. And I'm sure there's a whole host of things, but if you had to pick a couple that you constantly think about, what would they be?
Yeah, well, the thing that scares me at night is the infectious disease that's extraordinarily infectious and extraordinarily virulent, that doesn't get picked up because we're kind of ignoring it. And I just worry about that because, again, that's the most likely threat that we have from a public health perspective. That worries me a lot. I think that particularly at a time like now where we're at COVID fatigue. If you go back, then one of the benefits of being at APHA is we have some archives, and we've been around since 1872. So I can go back and look in our archives. I can pull the minutes of our governing council. I can pull the minutes of our journal or articles from our journal. And so I went back and looked at what happened after 1918. And by the way, there was flu fatigue after 1918. Public just didn't want to deal with it. Society hadn't essentially collapsed. Things, even though we purposely closed things this time, they closed things because they had to, because people were dying, getting up in the morning and were dead at night. And they closed things because they had to. And people were just tired, They just wanted to forget it as it began to kind of mitigate. We're now seeing that with COVID. And so my fear now is that something happens, another infectious on top of it. It's not going to be 100 years before we get the next one. So I worry about that. The second one, of course, is the impacts of climate change. I think that's the second one that I worry about a lot about. I think what gives me hope, of course, is when I talk to the young people in the field who are eager and energetic and eager to go to work and roll up their sleeves. We have a workforce of young people that are ready to do the work, that see the possibilities, and are hopeful. So they kind of give me hope.
I'm looking in the chat. There's a couple of there's a lot of commentary as everybody has a chance to look at the chat, and good comments. What are your thoughts in regards to the dual public health programs for medical, including nursing programs?
Well, public health, first of all, nursing has been the backbone of public health for many years, particularly community health nursing. So increasingly having nurses with a public health background, I think are going to be important for us to do. I would also argue that, we have a new undergraduate track for public health. There are now undergraduate episodic programs and kind of public health 101 that people do, kind of just think when we all went to school, kind of like psychology, everybody took psychology. So getting this basic public health training is important because I think it helps ground you in kind of the fact that there's a social contract that we need to have with one another. But I would love to see more lawyers take public health. I think it would help them. I think more engineers doing public health. I think it would help them. Again, help them understand the social contract we have, which I think has been broken.
Thank you for that. Great insight. So what do you think is the most effective approach to mental health epidemic in the country? Do you think it is a public health approach, a systems care approach, or both?
Well, it's got to be both. I mean, we have far too many people out here who have critical mental health needs that are not being addressed. Mental health is underfunded and not recognized as equivalent by any means to physical health. So first thing we need to do is get acceptance of mental health at the same as physical health. And then we need to get all these people out of the closet that have mental health issues. More than half of us, some would argue over 3/4 of us in our lifetime will have a psychological need / mental health need, whether it's episodic depression, going through a change in life, whatever that change may be, loss of a family member, loved one where we have to grieve. We all need that support. And far too often we treat mental health as though it's something that it's taboo, that we don't want to talk about, that it's somehow a weakness. Well, it is not a weakness. It is a condition just like diabetes or hypertension or anything else that we know we need to have. And I think we need to make sure that we treat it with the respect that it deserves. Now, from a population perspective, we need to think about many things. Right now, one of the things, as you know, is driving a lot of the hate, violence in our country is people who ought to know better saying things that they ought not say, and they know better. And those people need to be held accountable for their speech. I believe in the First Amendment. No one should leave this thinking I don't believe in the First Amendment. But there's the First Amendment, and there's stupid things you should not say because they have an enormous impact and they hurt other people. And if you do that, and you are in a position, if I did that in my job as a public official, I would have been fired, and I think some of these folks need to be fired. And of course, in our system, the way you fire them is you vote them out.
Another question to come up, and again, thank you so much for your insight and certainly thinking about this in the big picture. And this is sort of a couple of questions. I'll start with the first part of it. How do we make the case for making and sustaining the massive increase in funding for public health at the local, state, and federal levels?
We've got to make the Ben Franklin argument, about prevention. And it does mean we need to do a lot more economic modeling of our work. A little work has been done on vaccines and a little work has been done on maternal child health, but the vast majority of public health programs have never been evaluated. They fund the program, but they don't fund the evaluation, and particularly the economic evaluation. And the other thing that's important is that we need to recognize the full evaluation, the economic evaluation. What I mean by that is, lead is an excellent example. We know that lead exposure not only causes acute health problems, but it causes long-term brain challenges. It causes impulse control. It can result in people being more violent. And so we need to look at the savings when we put in lead programs to reduce lead exposure. We need to calculate the savings on the health side, on the juvenile justice side, on the criminal justice side, on the education side, because those kids don't do as well in school. By the way, those adults don't do as well either, because adult exposure to lead is just bad. And by the way, we have this enormous problem with lead in our water through all of our central cities that are aging now. Good news is there's money out there through the Inflation Reduction Act, and I'll address some of that, which doesn't get its due. But just know that there's an effort to try to reduce lead in our environment and lead in the pipes going into our homes. But my point is that we need to do more analysis. And then policymakers then need to take that and use that in their debates and their discussions when they make policy. If they do that, they'll see that public health is the best buy.
Certainly, your comments certainly about the lead in the systems, and obviously we're in very antiquated systems when you look today. And I know in the Chicago area we have the plumbing systems sometimes that are over 100 years old, and I know that's seen the same way in other cities. I'm sure the DC area, as well as other major cities around the country, it's like that. So thanks for those comments. The other part of this particular question was, how do we envision flexible funding such that we don't have so much categorical funding that can't be nimble and responsive and work across health inequities, which often have common root causes?
Yeah, it's interesting. The NIH has these big buckets of money they send to the NIH. Almost every line that funding that CDC gets, by the way, 70% of their money goes to local communities, health departments, communities, et cetera. It's so bad at CDC that if they want to send an HIV/AIDS person who's an expert in infectious disease to address Ebola, they have to get funding to pay that person's salary. They can't pay them out of the HIV/AIDS fund, except for a very short period of time with some discretion that the CDC director and the secretary of HHS has. That's how tight they have that. So first of all, they need to give them funding flexibility. Second thing is the way you hold yourselves accountable, because everyone's worried about where the money will be spent and will be spent appropriately. That's why you have accountability. That's why you have audits. That's why you have outcomes. Give them the money, hold them accountable, but they hold them accountable for outcomes. They get the outcomes. Do you really care how they got there as long as it was ethical and legal? There may be some policy differences on some of these things, particularly around things like reproductive rights. And there'll be some differences there, and I get that. But those barriers ought to be very narrow. And people need that. They ought to have the flexibility to do the job. If you give me a bucket of money and I reduce infant mortality, I'm going to save the federal budget a whole bunch of money. But unless you give me the capacity to work with the Women's Infant and Children's Program, Supplemental Nutrition Food Program, those are two, of course, food programs, working with counselors. If you don't give me the flexibility to work with a whole bunch of other people, put community health workers out in the community to get women in, to deal with domestic violence programs, because we know those things reduce infant mortality in the long run, improve pregnancy outcomes. We know how to do this. It's not like we don't have the science and understanding. We just don't have the flexibility to do it.
Thank you for that, and certainly we're addressing another question that came up in the chat as it was related to public health. What model or models do you see to improve maternal health? And you certainly touched on some of that in your comments.
Yeah, you know, in DC, actually, when I was the health commissioner, my predecessor, a guy named Reed Tuckson, they did just about everything they could think of to improve maternal health. We had outreach workers that went into the community. We had respite centers for pregnant women to come in particularly lower income communities, places where they could wash their clothes, so they could have clean clothes. And they didn't have to pay. A place for them to go to, they had to get there. And by the way, sometimes we even had money to get them there. Wash their clothes, get them out of the house, sometimes feed them because they didn't have adequate nutrition, make sure they got adequately vaccinated, got them to their doctor's appointments. If we identified a domestic violence situation, we were able to address that. Do some patient education. And we actually, and if there was a substance abusing pregnant woman, get them into treatment and care. And doing all those things comprehensively resulted in reduction in infant mortality in the District of Columbia and improvement in maternal child health. Data is very important. When I was the health director in Maryland, we had a sudden increase in infant mortality. We couldn't figure out why it was because it was in middle-class women, and not young teenagers. And it turned out who all had insurance, I might add. And what actually had happened was, this was when we were just beginning to do fertility treatment for women who were having trouble conceiving. And so you had a new technology that were being used by a range of providers. And what was happening was these women were in effect high-risk pregnancies that were not being cared for as high risk. They were not delivering in high-risk centers, and they were not being followed as high-risk patients. And we picked this up initially in the African-American community because we were looking at African-American infant mortality. But it turns out we missed it in the white community because it was a lower peak for a shorter period of time. So when we did the look back, we discovered that's what happened. And we also realized that we had women, again, delivering, not being treated as high-risk patients. So we worked with the American College of Obstetricians and Gynecologists and the pediatricians in the state of Maryland to make sure that women were identified early, gotten to the right place, gotten the right treatment, and were delivering at the right place, and we were to fix that. So good systems, good policy, in a multidisciplinary way is the best way to do that.
Thank you very much, Dr. Benjamin. We're getting close to the bottom of the hour, but we do have one other question here, and maybe we can end things as far as on this question. Is there a role for the APHA to address lowering harmful air particulates, particularly at the environmentally challenge is disproportionately harmful to the minority population?
Oh, absolutely. So we've been very much involved in this whole issue of the clean air. We were very much involved in helping pass the Clean Air Act, like many other organizations. We're part of a coalition with the American Lung Association, American Academy of Pediatrics, American Thoracic Association, to work with the Environmental Protection Agency to promote clean air policies with a particular focus on those communities where there are plants that are spewing hazardous smoke and particulate matter in the air. And then on a global scale, trying to deal with the ability of the EPA to regulate those plants and get those plants to go away, rapidly greening our communities. We actually have a center called Climate, Health, and Equity, which is targeted to improving climate change and addressing it and improving our health.
Well, thank you very, very much. Thank you so much for a wonderful presentation today. Lots and lots of comments in the chat. Certainly your overview, extremely helpful. We thank you for not only our presentation, but for everything that you do for our public health across the country. It's much appreciated. Sometimes not always probably recognized as much as we would hope it would be, but we do appreciate you and your team and your efforts, and we applaud you for all that. So thank you so much today. Thank you for your time, and please let us know if there's anything that we can assist you with.
Dr. Pence, thank you very much. Ms. Hodges, I appreciate everything.
Thank you, Dr. Benjamin. We appreciate your time, and Dr. Pence as well. So at this point, what we're going to do is just simply ask that you respond to a survey that will be sent out to you this morning in regards to the webinar, and what else we can offer any of the attendees here today, and other topics that may be of critical interest to you as well. And just a gentle reminder here that we'd love to see all of you at the 9th State of Health of Chicago event on December 14th in Chicago. That's an in-person event. We're so glad that we're able to resume those after 2 years of not being able to do that. So this is another opportunity to network shoulder to shoulder and to talk to people about these key issues that Dr. Benjamin mentioned today, and also Dr. Pence. So have a lovely day, remainder of the week, and we hope to see you at the next webinar or at the next event. Thank you again.